Okay, so I'm going to continue this part 2 on the echocardiogram. We're going to talk about measurements. I'm going to try to just walk the rest of the way through the parasternal long axis and apical views with measurements and what you do, what timings and stuff like that. And I want to back up to the parasternal long axis to start with because we need to also measure the LVOT, which is the left ventricular outflow tract. So the timing of this is actually early systole. So this is just after the valve leaflet's open. So if I got my EKG, P wave, QRS, T wave. So early systole is just after the QRS complex or the R wave. So our diastole would have been right on the R wave and probably just a frame or 2 frames after the R wave we're going to do this. Remember that we do all the other measurements when all the valves are shut on all those measurements. In this case, the LVOT is measured just before the annulus of the aortic valve when the aortic valve is fully open, the first frame that it's fully open. This is going to again correspond just after the QRS complex, but watch the valve itself to make sure that it's accurately done. LVOT is an inner to inner measurement, so we measure from the inside of this just before the LVOT. You're kind of in the narrowest flow area before the valve, but just before the valve within 2 or 3 millimeters. Do not measure on top of the valve annulus because you'll be too narrow. This measurement should almost always be close to or almost exactly 2 centimeters. Or 20 millimeters. That's very important because this number goes into the continuity equation, and that error can be magnified by the calculations. So make sure that we have a good, accurate LVOT measurement. So we covered the walls, we covered the LVOT now, we covered the aortic root, the left atria, and then in M mode we also covered the EPSS. Okay, so let's go just beyond this. We also want to look at components of the aorta. So I'm just going to draw the aorta here now. So we've got our annulus, which is kind of the beginning of it. This is where the valve would come. We have the sinuses of Valsalva. I'm going to over-accentuate those. They come down. Now let me make it not so big there. Goes down, and then it kind of comes out and becomes tubular at that point. So this is the tubular aorta, ascending aorta. And measurement-wise, and then of course you would come down from here, you would come into the ventricle, the membranous portion of the interventricular septum there. Right ventricle is on this side. And then this comes down and becomes the anterior mitral valve leaflet, posterior, etc., around, blah, blah, blah. What we're interested in the ascending aorta here is we want to be at a higher window than we typically are for even the wall measurements. So we should be really around rib space 2 or 3 to get this nicely level across the screen so you have a good accurate measurement. If we're measuring the annulus, we would actually measure at the annulus here to here. The aortic root is actually the widest portion of leading edge to leading edge. Through the sinuses of Valsalva, and then the sinotubular junction is actually from here to here. So it's where the sinuses come down and meet the tubular ascending aorta. And then we measure the ascending aorta up a little further. I personally want us to do this outer to outer. It should probably be done at the end of diastole. There's not really a consistency for adult echo when they measure this as far as the timing goes, but it's also found that to get a good size measurement would be best to do it when it's fullest, and that would be during peak systole. Pediatric labs do peak systole, many adult echo labs do it end of diastole because that's the most consistent stage, because systole can change depending on the load of the heart. So that's what we're going to look at. So the sinotubular junction, ascending aorta. I'm also going to have us measure this outer to outer because any aneurysm, which is what we're looking for, is measured outer to outer with CAT scan in the abdominal aorta, etc. So I'm going to teach my students to always do outer to outer. You may find some labs doing inner to inner or leading edge to leading edge, but I'm going to teach outer to outer for any aneurysm. That's ascending aorta. So LVOT, ascending aorta. So again, the annulus, the sinus of Valsalva or the aortic root, sinotubular junction, and ascending aorta. Okay. So we covered the Doppler already of the tricuspid valve. We covered the Doppler of the pulmonary valve. So now we're going to go to the short axis of the heart. There's no measurements that we need to take on 2D, but in Doppler, got our aortic valve, tricuspid, and pulmonary. So this will come over here a bit more. Our bifurcation of the pulmonary artery, pulmonary valve, tricuspid valve, aortic valve, right coronary cusp, left coronary cusp, non-coronary cusp, interatrial septum, all that anatomy that we talked about before. This is the right upper pulmonary vein. Okay, that's the left upper pulmonary, right pulmonary artery and left pulmonary artery. Apologize for that. So we're not going to do any 2D measurements, but we're going to show color Doppler on these. We're going to show some stuff I'll come up to in a second. First thing we're going to do is zoom up on the valve. So when I'm looking at the aortic valve, I want to zoom over the aortic valve such that I can see the walls that it includes, plus a little bit extra. So make sure that you're not too zoomed up on the valve. Therefore, the valve should look fairly magnified. Okay, and then you're going to see kind of a little bit of valve coming off, and then some septum and stuff like that. So other than that, your box is pretty much this here. What we're looking for in color Doppler on this, so we're going to do this in a 2D clip first. Then we're going to do a color Doppler on it. Color Doppler, if we have a regurgitation on the valve or a leaky aortic valve, it's typically in the center of it right there. And you're going to see just on the ascending aorta side of the valve, so if you sweep it up just slightly, we're going to get a little residual aliasing effect that lasts throughout diastole. So that's what we're looking for there. The other things that we're going to potentially look for is holes between the aorta and in the VSDs, and coming out of the aorta, either on the inflow side of it or the outflow side of it. We're looking for shunts where it's connecting the left side of the heart to the right side of the heart, because that should not be there. So 2D clip of the aortic valve, we're looking for calcifications, thickness of valves, masses on the valves, different shapes of the valves where it's not normal. We'll talk about that next quarter, when it didn't grow properly, and we're looking for holes and stuff where they shouldn't be. Okay, 2D clip of that, and then a color clip of the color box. We don't need to do spectral Doppler because we're at a very poor Doppler angle. So now we'll take this box off, and we'll focus now on, you can do this differently. Tammy and I were discussing if we instead stay in the center structures, so we'll do the aortic valve, and then we'll kind of go through to mitral valve, mid-LV, apex of the LV, and do those in the center first while you have a decent window, and then focus on the tricuspid valve and then the pulmonary valve. I personally go to the tricuspid valve first, then the pulmonary, then work my way down, but either way is perfectly acceptable. That method of Tammy's may help you stay in line in a good window without compromising your window, because once you move on to tricuspid valve or pulmonary, you might have to jump a rib space, and that could change your perspective. So that could be another way to modify your protocol a little bit to accommodate that. Okay, so next thing we're going to do is go to the tricuspid valve, and when I focus on tricuspid valve, here's my transducer at the top. I'm going to sector size down, probably about like this. I'm going to probably cut off a good portion of the pulmonary because at this moment, I don't care about it. So now I'm going to look at regurgitation and leakiness of the valve. Any valve structure, we want to look at the structure of it. We want to look at any thickening, any calcifications, any masses that are attached to it, or just any other structural problems with it. When we see it open, we want to see it open widely. When it shuts, we want to see it coapt together. Remember, zona coapta is that area where the leaflets are touching together. That needs to be reasonable so that we don't get leaks in the valve. Tricuspid valve commonly leaks and would look blue on the color Doppler. So first we're going to take a clip in 2D of it so that we can see that the valve is coming together properly. You can see some images on hearts where it comes together, but then there's a gap that's left at the end of it. And then when you stick color Doppler on, that's even more significant. Then we're going to stick a Doppler through it, just like we did. Oops, sorry. Try to get that right through the middle of it. We're going to stick a Doppler on it, a continuous wave Doppler on it, set at 2 to 4 meters per second, because we're going to repeat the same Doppler that we got on the last one. So how's that going to look again? We did that in long axis. We're going to set our color baseline, or our spectral baseline up fairly high. So there's our scale on the side here. This is going to be 2 to 4 meters per second. Okay, we're going to get a fairly parabolic shaped envelope, and then you might see just a little bit of an E and A wave on top there. This is going to be a pretty intense, or not intense signal. It's a very faint signal. So you really need to up your spectral gain to the point of seeing just a little bit of background speckle behind it, because this is a very low energy, low intensity waveform, even though it's a high velocity. We set the scale between 2 and 4 because this is likely going to be up around 3 meters per second, or 300 centimeters per second. Okay, so that's what our Doppler is going to look like on that. So we take a 2D clip of the sector size down over top of that. Then we stick color Doppler on it. We take a color clip of that, and we're looking for, we want to see the extent of that jet, but I have to see where it's coming absolutely through the tips of the leaflets. Then we've done what we need to for tricuspid valve. If there's a stenosis, we can go and optimize for the inflow of that and do some measurements on that. But we're not going to worry about that very often because tricuspid stenosis is not that common in adults. Okay, so then I'm done with the tricuspid valve. I'm going to move over to pulmonary valve. So I'm going to take that sector now. I'm going to kind of focus it in, narrow the sector size down over the pulmonary side, keeping things in relative perspective. Just like the other one, we might end up with a little candle flame type of regurgitation, which is very common among the population. We got our branches of the pulmonary artery that we want to keep intact. So right pulmonary artery, left pulmonary artery. This one again, we're going to sample with pulsed wave Doppler in the RVOT. And again, we're going to come up with a waveform that is below baseline because it's coming, the flow should be going from the right ventricle out the pulmonary. And it's going to look not quite as parabolic and rounded as the tricuspid jet is, but this should be enveloped because it's pulsed wave, it's range specific. Its velocity is going to be a little bit less than through the valve itself. We should be up around roughly 80 centimeters per second or 0.8 meters per second, depending on your system settings. Okay, so baseline up, this should take the majority of the height of that wave. Then we take off the pulsed wave and we put continuous wave through it. Okay, there's going to be a dot type thing on there. Put that just at the tips of the leaflets, roughly. It doesn't technically focus, but it actually does focus a little bit. The theory versus the reality. Okay, continuous wave Doppler, that's going to look similar to this. It's just a little bit faster than what the other one was. There's no spectral envelope or window, so now we simply are going to measure peak velocity on this. And we're going to be probably closer to about 1 meter per second, or 100 centimeters per second. Okay, so we measure that. I did forget to mention, just like the last one we did on the long axis, this is now short axis of the same thing. Put a caliper at the baseline where that wave starts, put it at its peak. We're looking at the slope. How much time does it take? How much time does it take from the beginning of this to there? So what we're interested in is the time. It's the acceleration time. So the time factor is really what we're interested in on that. The reason being is when it becomes pulmonary hypertension, that becomes steeper, and we get what's called a flying W shape, although that's a term that's really used for M mode. But it will still look like a W, and it'll have a sharp acceleration time if it's hypertension. So that is our pulmonary. So that's all we need for parasternal short axis. At the base, we take a clip of it. You can add a lot of depth to it, which will give perception of any kind of fluid collections outside the heart. And then focus in on it, only putting about 1 to 2 centimeters beyond the structure that you're interested in, so that you have a nicely magnified image without actually blowing up just the pixels with the zoom. We want that information to be as real as we can, and to save our frame rates. Okay, next image. So we've done our Dopplers. We've now looked at the tricuspid valve and pulmonary valve twice each. Once in long axis, once in short axis. Now we're going to move down to the mitral valve level. So it's kind of the base of the muscle. Okay, and we're going to look at mitral valve, which gives us kind of that fish mouth appearance. The opening of this is the mitral valve orifice. Okay, this is posteriorly located in the heart, so it's closer to the spine. If I was to sweep through it, I'm going to first draw our septum in here. So interventricular septum, RV is on top, so this is LV here, RV there. If you're looking at it and sweeping through it, if I'm looking up towards the head, the flow comes in here. This is the left ventricular inflow. This would be the outflow tract, would be kind of in this area here. The flow is going out where that green is. If I swept through it, the aortic valve would sit just about right there. Okay. We take a 2D clip of that, and then we put a color box over. You're going to put the color box over the mitral valve, making sure that you include the whole annulus, maybe even just a little bit bigger to include the whole LV would be appropriate. What we're looking for is aliasing jets, which will probably be in blue, but it could be other colors as well, kind of an aliasing blue. You're looking for the location where that is. Is it side to side? Is it in the middle? That gives us a locational reference to what's going on from a 90-degree axis to what we saw before. All right, so you take a 2D clip of this, you take a color clip of this, and that's all we need for mitral valve. Next view is the, we're going to draw short axis at the base, or at the mid-level. Mid-level includes the papillary muscles. Remember, your posteromedial papillary muscle sits by the septum, and the anterolateral sits by the lateral wall of the free wall. This papillary muscle can have dual blood supply, whereas the other one is kind of on its own, so it could be compromised in a heart attack. No valves in this level. The papillary muscles should not be free-floating. They should be attached to the wall. This should be round. It should not be oval this way. It should not be oval this way. If we're oval this way, that means we're too high up or too low, and when we're angling in it, we're getting it obliquely. If it's too wide, oval in a wide shape, then it means that we're rotated incorrectly. We need to rotate it so that it's round, unless the heart truly is abnormal. This is LV, this is RV. Okay, you take a 2D clip of that, making sure that you see the inner walls really well, because we're going to be gauging people's myocardial perfusion based on how well those walls squeeze. So we're looking at the squeeze of the wall, meaning you have to see the wall. If it's dark and hazy, you need to get a better image. Okay, beyond that, we're going to go down to the apex level. So we're going to have a small, sorry, I got lights went out here. We're going to have a small residual chamber left. Here's the muscle. We just got a little residual chamber. The apex muscles from the right ventricle are going to kind of be there. We shouldn't really see any chamber anymore on the right ventricle from that septal area, although we still have a septal section of the aortic, or of the apex area. Remember this, get the heart. Okay, so we're 90 degrees to this. So my indicator side here is going to be, we're starting at the valves at that base level. Then we sweep down slightly to the mitral valve level. Open this up. And then I'm sliding my transducer down so that I'm perpendicular to it here, looking at the papillary muscle level, mid-LV. And then I slide down even further to be right over top of the LV apex, so that I just have that little bit of residual volume left in the apex area. Indicator in that is going to be pointing more towards the left shoulder of the patient. So that's all we need, is a 2D clip of that. We don't need color unless you are concerned about a shunt. Then we would actually do color Doppler over the whole septal area all the way up to the aortic valve. That is our parasternal short axis views. Now we go to the apical views. First view we get is four chamber. So it's important to line up the four chamber well. Draw this in real quick. Okay, so transducer should be directly above the LV apex. That's going to be your main focus. Put that directly underneath your transducer. We do not want it off to the side either way, because then we're going to shorten things. We're going to see them not in the right angle. And to get my good Doppler angles, I need to be 0 degrees, and we need that to be exactly over the top. So good four chamber view. What that means is I have to have balance of all four chambers open equally. Remember that if we're looking at the tricuspid and mitral valves of the heart, you can see on the heart model, if we're looking at those valves, we're at the posterior aspect, which is near the spine. If we're looking at the semilunar valves, which are here and kind of up underneath here, so they're up a little bit anterior, so when I tip up, that's when we see those. We only see the tricuspid mitral valve at the posterior aspect of that, lots of trabeculations near the back, etc. So we're really looking at the posterior aspect of the LV when we're looking at four chamber view. From this view, if we're getting this incorrectly and we're mal-rotated, not rotated enough, and the rotation on this, by the way, is to have the indicator on the patient's left side, but more toward the floor, and turned up this way just a little bit, okay? So we're coming in from here, we've got this in, we're at the apex. We want to be in line with the four chambers, so you can see that it's kind of rotated up just a little bit with my sector. It's not down to the floor, it's up just a bit. Okay, then I'm going to sweep it up anteriorly to get the aortic valve in later. Okay, so what do I see when it's mal-rotated? You might see ventricle, right ventricle here. Okay, you might see the right atria. It might be full and decent. And then you get the septum, comes around. I kind of see some left ventricle. I see some left ventricular chamber, maybe a little bit of valve here. And then for whatever reason, I don't really see anything back here, but what I do see is kind of oblong kind of a fluid-filled space there. It's going to be black like the fluid in the chamber with some white and stuff around it. But if I see this, that means that I've rotated incorrectly and I'm pointing more straight towards the floor if the patient's on their left side, and I need to counterclockwise rotate, keeping the right side open, but then also being able to get the left side open. I need to see the full atria just like this. If I don't see that, I don't have a good enough view. Now, this is the coronary sinus. So it runs along posteriorly behind the left atria, and this is a long axis view of that. So in pediatrics, this is useful because you can actually just take this view and tip it more posteriorly towards the spine and see the size and caliber of that, because that might indicate that there's an anomalous connection going on. Okay, so be aware of that. The other thing that we're going to run into is if we tip too anteriorly, you're not going to have a nice conformation of the valves here. You can actually open up into the aortic valve, which you do not want to do at this point. Okay, in this view, we're not going to do that this quarter, but for the first quarter, but for 253, we are in 254, we are going to measure the Simpsons. So I'm going to show the Simpsons real quick. Simpsons, you can kind of not zoom in, but you're going to take your depth down to about here and get your sector size so that you have just the LV. You need to see the walls really well. And then what you're going to do is in diastole, so right on the R wave, you're going to scroll to that point, and we are going to measure the inner walls of that, starting at the annulus. The important parts on the Simpsons method of discs are the annulus on both sides and the peak, wherever that is. So we're going to start there, we're going to go into our calculation package, and we're going to trace all the way around the inside of that, ignoring any papillary muscles that might be evident there. Okay, then we lock it on the other annulus, and then it automatically draws a line across there. And what it does is it creates a whole bunch of little discs all the way through here. That is the system's way of calculating miniature cylindrical volumes and then adding them together to create a volume. The other important thing there is we've got the middle of that chamber to the middle of the annulus plane, and that maximum length is taken to add to create that volume. So we have an area length method to create a volume out of this. So we do this first in diastole, and then, so that was on the R wave, then we do it just after the T wave, that full systole, very end of systole. So this is end, diastole, end, and systole. Okay? So you do it when it's maximum volume, so you're going to scroll back and forth, and then you're going to squeeze it in until it's the most, and you're going to measure at that point as well and compare those two volumes. So Simpson's method of discs is what this is called. So Simpson's method of discs, this is again creating mini discs all the way up here and then adding those volumes together from a cylindrical calculation. We do this in both 4-chamber and 2-chamber if you're going to be accurate. A lot of labs do just the 4-chamber. This gives us what's called an ejection fraction. Or just EF. And doctors, when they're having a scan in emergency, they're honestly most of the time just looking for what is the EF, what is the ejection fraction. Normal ejection fraction is between 55 and 65%. Okay? So that's that, and it's also called biplane method of discs as well. So biplane meaning I need to get it in 4-chamber and I need to get it in a different chamber, which is usually 2-chamber. So we'll measure in both of those, we'll do Simpsons. For the first quarter of 133, 130, we're not going to have you do the Simpsons as part of the lab. but keep that in mind as far as how that's done. Okay, so we would normally do our Simpsons first. Just erase all this in here. Redraw the valves. Okay, so we go back out. We want to be back to you want to see a good centimeter to 2 centimeters beyond the heart in this case, the left atria. Okay, then the next step is we're going to take a clip of this. Usually it's a good idea to take a clip of the same image you would use to do your Simpsons, so the doctor can go back and recalculate that themselves if they feel they don't see it very well on your images. And they just need that visual perception. So you want a clip of this in 2D, then you want to freeze it, do it diastole, scroll forward, do it in systole, take a picture of each of those with the calculations. Then beyond that, we can do what's called MAPSE. I'm going to show you MAPSE. I'm not sure we're going to have you do MAPSE. We are going to have you do TAPSE. So this is basically mitral valve systolic plane excursion. What we're doing is running an M mode through the annulus of the mitral valve on the lateral wall. And what we're looking for here is you're going to see the M mode is just going to show this. You're going to see a bunch of stuff up here, as it goes across the M mode. That's this. Then it hits this next interface here, so you might see some light shades of gray as it's going across. But we're looking for this annulus, which is going to be a darker signal. But it's going to come across, and then it's going to come up. Like this. It's going to raise and fall. So basically when the heart squeezes, it twists, it squeezes this way, and it thickens. What we're looking at on this, being M mode, is that this segment of the wall, that annulus, is moving away and towards and away the apex. And the more this rises, the better the systolic function. We'll talk about this more later. So a MAPSE is how far this comes, how far this rises. Okay, and that measurement is going to be an indication of systolic function. A system might not let you measure like this. It might have you measure here and here. So you're measuring the low point and the high point, and you're just looking at the distance straight up to those. That's MAPSing. Okay, back to this. Gonna redraw that. Okay, then we get into Doppler. So now we're going to do a pulsed wave Doppler of my mitral valve. So we're going to take our cursor through here. Our sample volume is going to be just into the LV side of the tip of the mitral valve. It usually sits a little bit lateral from center. You want to be at 0 degrees. And then your Doppler signal, you're going to bring the baseline near the bottom, and you're going to get your E and A waves from this. If there's a regurgitation, you'll see some regurgitation go down below on either side of that waveform below baseline. But again, we're going to take our baseline to about here. Okay, we're going to bring the baseline down so the bottom of the image is here. And this should be near the top of the image display so that we can get the best possible measurement. On this, what we're going to measure is the peak E. Here's your A wave. We're going to measure the peak of the A. We're going to do the decel slope. Measures to baseline. So that is called the deceleration time. Okay, so deceleration time is the slope of this. That's important. And then additionally, we could measure where the A wave starts to where the A wave finishes. That's called the A wave duration, or A dur. Okay, that's how long does it take for the A wave to occur, and we're going to compare that to the pulmonary vein if we measure that. I'm not going to have us do that in lab. I want the E peak, I want the A peak, and I want the D cell slope. Okay? That is on a normal heart, that's what we're going to measure, and we're going to kind of stop at that. There's other things we can do if it's abnormal. We'll talk about those in next quarter. We'll use CW next quarter when we get into pathologic conditions, but in a normal heart, this is all we're interested in right now. Okay, then since we're in Doppler, we're going to do a couple different things. We're going to do a tissue Doppler, and we're going to do a spectral Doppler of the pulmonary veins. The right upper pulmonary vein, as we know, comes down here. Okay, you got your descending thoracic aorta there. Left upper goes that side. Now we're going to take our pulse sample and place the pulse sample in the pulmonary vein there. It's going to go up there, and you're going to line that up. You might need to come a little bit lateral, coming in from this side of the heart, angling through to see that really well. Then we'll draw out our waveform. If we got a sector size, we want, or not a sector size, excuse me, the image size, we want about 2/3 on top of here, about 1/3 on the bottom, because we're going to get an S wave, a D wave, and an A reversal, and then it goes to S, D, A reversal again. This A wave is compared to the other A wave on the mitral valve that we would have measured if we did that. So that's how long does that take to occur. We could potentially measure the velocity of this A reversal. So this is called the AR, which is A wave reversal. This is the S wave, this is the D wave. So S wave is the systolic forward motion through the pulmonary veins, and the D wave is the diastolic motion through the pulmonary veins. And you wonder, why are we getting forward flow in both of those? Well, the pulmonary vein doesn't have any valves in it. When the ventricle is contracting, so this is during systole, that causes the mitral valve to shut. The mitral valve is filling, so I get forward flow out of the lungs into the atria. Then, when the heart relaxes, we get that, for a moment, we get a lack of the push. So that gives us a bit of a pause. And then we get diastole, which then I got that big buildup of fluid inside the atria. It opens up, and a big rush of fluid comes out with the E wave in my mitral valve. This causes forward flow in diastole, and it goes throughout all of diastole. And then when the atria kicks, that last little kick from the P wave, this goes backwards, back up towards the lungs. So this is like squeezing a tube of toothpaste in the middle. If I squeeze it, some of it's going to go out the right way, and some of it's going to go back the other way. And that's what's happening in the atria because we don't have valves inside the pulmonary veins. So that is pulmonary. Okay, let's draw that back intact. Get rid of all this. Okay. Next thing, and this is something that we'll probably do later in our protocols, but we're going to do tissue Doppler. So a specialized Doppler feature is to be able to go on the annulus and take a pulsed wave sample of this with special filters that are specialized for the tissue movement and not the velocity of fluid. So in this, we're going to bring our baseline near the top. And we're going to look for very low velocities. So we're going to actually have a very intense signal. And it's going to be the E wave and the A wave. We are going to measure these. So this is all diastole. So this is called E prime. So it's usually a small e or lowercase. And A prime. If we're to complete this, there's actually after that, there's actually a systolic wave beyond that. So this would actually be S prime, small s prime, on the tissue Doppler. We compare this to the mitral inflow that we saw earlier. We're also comparing the size of the E and the A waves to see that the E wave should be bigger, but it's not always. And if it's not, we'll get into that with diastole. So that is tissue Doppler, so we will have you do that. You're going to do that on this annulus, and that's the lateral wall, and then you're also going to do that on the septal annulus as well. So they should be similar. This one's going to be a little bit bigger, but we're talking about velocities around 8 to about 20 centimeters per second. So it's very slow compared to the flow that we're used to looking at. Okay, I think that's it for that. If we then move to, I'm just going to erase the Dopplers here. Couple ways you can do this workflow wise. We can either then go to the tricuspid valve, or we can go and angle up to the aortic valve, and that might be easier to start with, but while we got this drawn on the board, I'm going to do a right ventricle here instead, and tricuspid valve. So in the right ventricle, we are looking at the tricuspid valve. We're looking for calcifications, thickness, masses, things that are attached to it, broken valves, etc. Looking to see that it coapts and closes properly and does not leak, although tricuspid valve virtually always leaks. The leak will also be in blue. This is the best angle that we can possibly get. But to get this well, we do what's called a modified apical view, meaning that we bring the transducer from the peak of the apex of the LV to being over the peak of the apex of the RV. To do that, you're actually going to come a little bit more between the pulmonary or the parasternal views and the apical views. So you're going to come partway between to be right over top of the right ventricle. Rock it so that it lines up straight over that, and you're looking straight down in. That's going to get us the best Doppler angle. And once again, for the third time, we're now going to take the spectral sample of that regurgitation and measure its maximum velocity. That's the TR jet. Again, I'm not all that concerned about the EA wave of that because tricuspid stenosis is not that common. So that's what we're going to do on a regular routine basis for echo. Now, that is getting us a great Doppler angle, but we're going to now measure the size of the right ventricle. And this is now how the ASE recommends that you do that. So I'm just going to redraw this so it's not so messy. We're actually going to come, and we're going to use the left ventricle now to create a window to the right ventricle. So I'm drawing it a little bit off axis here because what we're going to do is come lateral to, so go to 4-chamber and go more lateral to it now. So the transducer's coming in from this perspective. Okay, so now I can see the muscles really well because I've got a big fluid structure here that creates a very nice window for us. Measurement for this is going to be measuring across the annulus of the tricuspid valve. So that you measure, and then you measure the widest portion of the right ventricle itself. That could be midway, that could be just a little bit up into it, but you're going to measure that maximum diameter of it in that perspective. And then you can also measure from the apex of it to the middle of that annular plane, like that. So this is a proper RV measurement according to ASE standards. All right, just because I'm going out of the top of my head here as I go through this, I forgot that we need to also measure the atria and compare the left and the right atria from the apical 4-chamber perspective. So this, a lot of times we're going to do a volume measurement for this, so it's like a Simpsons. So we're going to start at the annulus, and we're going to trace around the inside of the chamber. Okay, if I've got a right upper pulmonary vein coming off of there, I ignore it. We go around it to the other annulus. We lock it. It draws the line across the annular plane. It creates those mini discs that we talked about before, and creates the volume, and it measures the center of that annular plane to the maximum distance back in the atria. And that could be a little bit off angle on either side, but that's how you do a volume. The other way I'm going to teach you, just because some labs might still do it this way, I would do normally the same thing on the right atria, and I'm going to do this in 4-chamber and 2-chamber. The other way that's done is called the major and minor axes. So I'm going to draw an imaginary line across the annulus, and I'm going to go and set a caliper there and the maximum distance. That's my major. Okay, and then I'm going to take the maximum distance across where it's most dilated, 90 degrees to that, and that is my minor axis. So we'll do those 2 measurements, and then we'll measure it again from 2-chamber view. Or that's really all we do, but we compare the size of visually compare the size of the left and right atria to see that they're both open as much as they can be, but the right should be slightly, it's usually slightly shorter but wider than the left atria, and both of the atria are about 1/3 of the size of the ventricles that they're related to. So they symmetrically speaking, they should be like that. If the atria are now the size of the ventricles, then you probably have something going on. So that's atrial measurements. Okay, now we're ready for 5-chamber. So we're tipping anteriorly. We want to see the valve tips. If you're not seeing the tips, you're not seeing it good enough. Okay. Don't be so concerned about seeing the 4 chambers or the 5 chambers. So we got the right and left atria and the right and left ventricles. I'm concerned about seeing the aorta open with the middle of the aortic valves, because this is where we do our Doppler to determine how blocked up it is. Once we got this view, we'll take a 2D clip of this, then we're going to take a color clip of it. You might even zoom on it. We're looking for regurgitations, which would come back in red in this case. So come up here. It's very low pressure during diastole, so we get a lot more flow than we would for a mild jet than we would in another chamber. So this is the biggest looking jet. There's different ways that we can calculate that we'll talk about next quarter. So this goes back here for flow. We're also looking at the aortic valve to see if there's anything hanging off of it, any thickening, any calcifications, broken valves, flail leaflets, different things like that, or even valve replacement issues when we get to those sections. So we want to get lined up to the best angle possible. So we've angled and tipped forward anteriorly a little bit. Now we're going to come a little bit lateral again with our transducer so that we can get a nice straight line through the middle of that valve. The first Doppler we're going to take is in the LVOT, left ventricular outflow tract. We're going to bring our baseline near the top, and we're looking for kind of a parabolic. This is pulsed wave, so it's range specific, and like the pulmonary, now we have an enveloped thing here. We don't do acceleration time on aorta, but we do trace it. So part of that is we're going to start at the baseline, and we're going to trace all the way around the outside of that waveform back to the baseline there. This gives us what's called a VTI. That's a velocity time integral, or it could be TVI, time velocity integral. That's going to go into the calculation. It shows us basically the mean velocities that are going on as a whole. It's measured in centimeters as the units. And we're going to trace that, and that's going to tell us some insight onto the flow of the aorta, or that's about to go out of the aorta. And then with doing that, it also gives us a peak velocity when we do that tracing. So that's the PW, that's what we measure on it. That's every time we do an echo. Then we're going to switch to continuous wave. And we're going to be Dopplering right at the tips of the leaflets. This should be theoretically the most narrow portion of that. So now we're in continuous wave, and we're going to have a similar looking waveform, but a little bit higher velocity. Because it's continuous wave, we don't have enveloping. And what we're going to do here on a screening process is we're going to measure the peak velocity of that aortic flow. There could be regurgitations going on that are going to be above baseline and a lot higher velocity than what our waveform there is. Not concerned about that. We're actually going to kind of cut that off. If it aliases, no big deal. I'm interested in this velocity at this moment. If we do have regurgitation, we're going to go to continuous wave Doppler, which we're in currently, move the baseline down, optimize for this, and we're going to measure the slope of that to the baseline. We measure what's called the pressure half time. That's not something you need to know first quarter, that's something you need to know second quarter of echo. That's how we're going to calculate the severity of that jet. That's aortic valve, so that's all we need. So really on a basic echo, what we're looking for is the normal velocity. This should be less than 2 centimeters per second, or sorry, 2 meters per second. Usually this is about 1.5 meters per second. This is like about 1 meter per second. Higher flow than the right side of the heart because of the pressures being more elevated and just more pressure pushing it out. So that's kind of what we should look at for aortic valve. Okay, after we're finished aortic valve, this information in conjunction with the LVOT 2D diameter, which should be 2 centimeters, or close to that, that information gives us the ability to calculate a valve area for the aortic valve. That's a really, really important measurement. Okay, 4-chamber, 5-chamber is done. Let's now go to the 2-chamber. So I'm going to redraw the 4-chamber because I want to emphasize this point. If I want a good 2-chamber view, I'm going to go exactly down the middle of that chamber. I want it lined up straight in my sectors because when I turn 90 or 60 degrees on this, we're going to end up in a very nice 2-chamber view. And I'm over accentuating this a little bit because again that wall can dips back that tip of the ventricle. This is the anterior mitral valve lymph node on that side. The tip of the ventricle takes an inferior dip. So inferior is this wall here. Okay, we've got our coronary sinus is an inferior structure. We've got, if you can see it, and you can often see it, as the left atrial appendage is on the anterior aspect of that. For this image here, we're going to take a 2D clip of it. Just color the walls here real quick. We're going to take a 2D clip of this, and then we're going to stick color Doppler over this, showing the color flow through this. If there's something going on, we're going to take another pulsed wave of the Doppler of that valve, but typically we don't do anything further than what we did in the 4-chamber unless there's something wrong. So that's fine. We may take another volume of the atria, and we're going to take a Simpsons of the ventricle. This is the biplane, this is the other plane that we use. So Simpsons again, all the way through the apex. See those inner walls good. It does those lines. Maximum distance across. And that gives us the other part of the Simpsons and completes that formula that gives us the volume. You could do the same thing on the atria also, getting us a volume of diastole in particular of the left atria, but you may also compare it to see how well it's squeezing. And you might also do that in diastole in a clinical setting. Other than that, 2D clip, Simpsons, and a color clip of the flow through there, and that's all we need. Okay, then same perspective that we have, we turn another 60 degrees, and we should end up with almost what we saw in the very first image we took, which is the parasternal long axis. The important part about this long axis is that we need to see both the mitral valve and the aortic valve in the same image. They both need to be opening and closing, although they're going to be at different times. And we're going to take a 2D clip of this. We're looking at the walls in it because now we can see without the obstruction at the apex, obstruction of the rib shadows, that is. Then we're going to take a color Doppler of that area as well, looking at the flow, looking for regurgitation from the mitral valve, regurgitation from the aortic valve, This one would be red, this one would be blue. And we're looking for any stenosis or other things like that. This is a great alternative view for doing our aortic Dopplers if we need that. So that is the extent of the apical views. That's all the measurements that we take. Remember, we did our tissue Doppler, we did our pulmonary Doppler, Doppler through each of the valves. Apex, the apical views are where we really do most of our Doppler because it provides that 0-degree angle that we need and more accurate. Later on, we're going to talk about wall segments and kind of how to evaluate those walls and how important those are to us, particularly for coronary artery supply. This view, incidentally, is exactly the same view as your parasternal long axis, but we're seeing it now from the apical perspective rather than from anteriorly. Trying to think if I forgot anything else. That should, in essence, be the basic echocardiogram. Further than this, we would be looking subcostal from underneath up through the liver, and suprasternal notch up in the neck, looking down at the aortic arch and the vessels and stuff up in those areas. Beyond that, that is an echocardiogram. I'd ask for any questions, but nobody's going to respond because there's nobody here. All right, good luck.